Well, good afternoon. We are back. Hope you enjoyed the networking and exhibitions. Our next speaker is Dr. Stephen Klauty. He is the Senior Medical Director of Digital Health at Summa Health and also is an invasive cardiologist. Dr. Klauty, I am turning the floor over to you.
Okay, thank you. Thanks for the invite. So I'm Stephen Klauty. I'm a physician at Summa Health. I'm an invasive cardiologist by training, and recently have gotten more into the IT side of things, taking the position as in digital health as a senior medical director. One of my goals is to help bring the clinical experience to IT and improve the patient experience at the same time. So the title of my talk is Clinical Perspectives on Telehealth and Using Remote Patient Monitoring to Address Capacity Management. And some of that is going to be the challenges that and the tools that we use or are trying to use with respect to patient monitoring to extend capacity. So just a summary of the talk. First, I'm going to briefly review the issue of healthcare capacity. That's been discussed quite a bit, so we'll try to keep that brief. Second, discuss in general terms how to approach finding some of these solutions, particularly with respect to new tools that are available. Are they clinically relevant? Third, review the care continuum pathway and try to look at that and see where can we address the implementation of those solutions. Lastly, I'm going to talk about two remote patient monitoring solutions that Summa is addressing. I'm going to talk about their differences and similarities. One of those were implemented at Summa Health, and the second is in process. So as many of us have been talking about on this meeting, there's been a decline in healthcare capacity, and there's multiple causes, and the keynote speaker pointed that out very well and very clearly. COVID is clearly the major player here that has changed how we deal with healthcare capacity. It's caused crowding in the emergency department, which in turn crowds and increases volumes for admissions, observation, and the ICU. And this places pretty significant constraints on traditional hospital capacity. The second issue, as has also been pointed out, are staffing limitations. And this is almost universal in healthcare at this point. And interestingly enough, it's not just an issue with clinical staff, nursing staff, and physicians. It's also with IT and a variety of other support services in healthcare. So the consequences of that are, well, limited beds. So if you have limited beds because they're being filled up with COVID patients, you have to create beds. And one of the ways to do that is to decrease or decline the elective procedures that you might otherwise be doing, whether that's in orthopedics, cardiology, and so forth. But those are high value procedures, and that can be deleterious to hospital finances. So not only that, the consequences are also a decrease in patient satisfaction, an increase in provider burnout, all things that had the healthcare system functionally in the wrong direction. So when this issue came up, people jumped on that and try to control what they can. And it's in its simplest fashion, it's about how can you address capacity, the traditional hospital capacity. You fill less beds and then discharge expeditiously so you can open more beds. So is there a solution to this? Well, one of the solutions is an integrated approach, and that integrated approach brings IT into the conversation in a collaborative way with physicians. Clinicians often are on the outside of IT. They hear and see things that they think they're interested in that can be helpful, but oftentimes individually as an idea, it can be very hard or difficult to implement. It can be expensive to implement. And so trying to understand what those tools are and whether they're appropriate becomes important. IT is very good at bringing solutions, but are they the right ones? Particularly when you're talking about new tools in which the clinical outcomes are not clear. So it sounds easy, just bring clinicians and IT together. But for small and medium-sized institutions, that may not be as easy. So for example, at Summa, we have not had a chief medical information officer. We now have one. And so for a small institution, do they have one? Do they have staff to collaborate for these solutions? Do you have support for that, for those teams? So for our experience, our approach, driven by our chief information officers, to identify IT leadership to participate in these processes, identify multiple clinical business partners, bring them into the IT governing structure for both short-term projects and long-term projects to assist in governments. And in particular, the assistance of clinicians in addressing short-term projects to answer the question, is the solution that you're bringing, is the IT solution that you're bringing, is it going to be worthwhile? Is it going to solve a clinical problem? So this is a slide that depicts the care continuum pathway. And of course, you know this. And I bring this up because I want to point out some locations where we can utilize telehealth and remote monitoring roles. So starting on the left side, we start with the patient pool. So who are your patients and what is their digital readiness? Do they have a flip phone? Do they have a smartphone? Do they have Wi-Fi? These are important questions because if you're going to stand up a telehealth solution, a remote patient monitoring solution, the understanding what their digital readiness is essential to be able to do that. So for this patient pool, even before they start asking questions or calling into an office with a problem, to understand how to address capacity management in part depends on how well does your patient pool do self-guided care with respect to wellness, with respect to chronic disease management. So what are your patient engagement products around self-guided care? What does the front page of your organization website look like? Can they be directed on that website to solutions that can give them answers directly? Can they be directed to asynchronous visits or for on-demand clinic appointments? And so that's an important part of an upstream feature that is important for understanding how can you address capacity management, which is effective self-guided care by your patient population. Well, if that doesn't work, well, the patient is going to call in to their primary care physician, their specialist, with questions. And the important point here is the triage is going to be key. The person who takes the call then has to address the question, is this person sick enough to send them to the emergency room? Or should they be thinking very carefully about other strategies? Should that patient be, in fact, referred to urgent care? Maybe their status is actually relatively stable. They need an inpatient office visit, maybe a mobile clinic or a retail center. Another possibility that we would like to introduce for those people doing triage is to consider a telehealth visit, perhaps a synchronous or even an asynchronous visit. And for patients in whom there's a substantial concern about that patient's vital signs, somebody who you might otherwise send to the emergency room or some other facility, can you set them up with a remote patient monitor? And that has the potential to decrease admissions. So that's one of the interventions prior to coming to the emergency room. Well, you can't do that for all patients, obviously. Patients have illnesses and issues that require emergency department visit. And the usual approach there is if the patient is sick enough and they need additional monitoring, well, then that patient is moved to an observation bed or they're admitted to the hospital. Well, a third approach here is not just to move straight to observation or admission, but as this red line that I've placed here shows, that you can potentially expedite discharge from the emergency room, set them up with telehealth visit, synchronous or asynchronous, and monitor some crucial or critical vital signs that gives you a tool to be able to keep the patient safe and thereby avoid the admission either or entry to an observation bed. And so that strategy helps with your capacity. Well, patients are going to be admitted for observation and admission beds, and so they will have their medical issues addressed, and the care team will then process that patient toward discharge. The care team will then try to figure out, okay, what's the next step? Post-acute care facility, home. But there is, once again, another option. Is it possible to use remote patient monitoring sooner in the discharge process? And you might be able to send that patient home earlier, monitoring some critical vital signs to keep them safe. And can that process in turn lower readmissions? So in this care continuum pathway, I've added these red arrows, which shows you locations in which you can interrupt the natural, what is otherwise the natural flow of process for the patient going to the ED, getting admitted, getting discharged, and then going to a facility or home. Now, I did put another item here called a hospital at home, and my talk's a bit too short to be able to address that, but I think a lot of us think of hospital at home as sort of the pinnacle for telehealth and remote monitoring. It's the ultimate telehealth and remote monitoring solution. And of course, you can get to hospital at home from a variety of locations, whether it's the ED or the office or even a post-acute care facility. But we are not there yet. I know there are a number of organizations, some of whom might be on this conference, who've stood up some of those solutions, but that is certainly a work in progress. For the clinician, the question is, does remote patient monitoring work? And this is really challenging because there are really, in clinical trials, mixed results demonstrating the benefit of remote patient monitoring. There is some support for the role of remote patient monitoring. The Ochsner Medical System has demonstrated a 40% improvement in achieving blood pressure goals. And another health system, Essentia Health, they showed a small but a 2% decrease in 30-day heart failure readmissions, which as a category has been very, very stubborn for post-acute care management, for telehealth, clinical calls, and so forth. Very tough nut to crack to decrease readmissions. So in looking at the available information, I found a paper that I think addresses this. And the title is, Does Remote Patient Monitoring Reduce Acute Care Use? And this is a systematic review in the BMJ journal from this year. I included a copy of the results and the conclusions, then highlighted some key points here. So from the results, they looked at 91 studies, so quite a few studies, and they found about half of those, or a little under half of those studies, showed that remote patient monitoring could reduce admissions, length of stay, and emergency department presentations. But the other half actually did not show any benefit. So there clearly, there may be an issue with patient selection here. What they were able to identify is that remote patient monitoring of COPD was more effective at reducing emergency presentations than remote patient monitoring of other disease conditions. They also showed some benefit for monitoring of cardiovascular disease, invasive monitoring being a little bit better than non-invasive monitoring, but still there was some benefit. And so they concluded that remote patient monitoring can reduce acute care use of patients with cardiovascular disease and COPD, but the effectiveness varies within and between populations. And remote patient monitoring's effect on other conditions are somewhat inconclusive because we simply don't have the studies to say whether it's beneficial or not. The last sentence of their conclusion I highlighted because I think it relates to us in particular. These findings should be considered alongside other benefits of remote patient monitoring, including increased quality of life for patients. Obviously, if patients desire to be home and they're safe to be at home, remote patient monitoring gives them that opportunity. It may or may not decrease the readmission for that patient, but the quality of life for patients is relevant. And for us addressing the issue of capacity, clearly, if you're able to safely discharge a patient with remote patient monitoring and have them at home, you've suddenly increased your capacity. And so there's benefit there. I think I'm going to go back briefly to my care continuum slide and show you the first location where Summa Health started a remote patient monitoring solution. And this is for COVID-19 patients who entered the emergency room, in which we were trying to decrease the admission of some of those COVID-19 patients. So let's talk a little bit about that remote monitoring solution. So this is an ED to home solution with remote patient monitoring oxygenation in positive COVID patients. This is a select group of patients that were chosen in the emergency department. So it's certainly not all, but they fit certain criteria. As part of the entry into this program, those patients had to bring their own device. They needed a Bluetooth connection. We did not need a long-term contract with the vendor, and our organization was able to purchase monitoring devices and then give it directly to the patient. These are oxygen monitors, and they're designed to monitor oxygenation continuously. And the devices are also set with trigger points, trigger values, in which certain alerts are sent to a vendor-driven dashboard. And these alerts are actually organized in an escalating fashion. So, for example, if the oxygen saturation was less than 90%, an alert would be sent out. But if it was worse, a nursing call would be sent out. And if it was even worse than that, well, then a provider call would be triggered. For this particular solution, these alerts were fixed for all the devices, not individualized to the patients. And the vendor dashboard was used to monitor all of these alerts and statuses. In addition to the alerts, a second feature, which is very helpful in this situation, was employed, which is a patient engagement questionnaire. And daily questionnaires were sent to the patient where they would answer those on their mobile application. And then if there are concerning responses, that's addressed by the care team. These patients were selected on agreement by the emergency department attending and the pulmonary service. For Summa, it turns out this was only operational for a few months in 2020. They did about 15 patients, and they noted 3 readmissions for patients who were unable to stay at home. These patients were not billed. Typically, the monitoring was about less than a month. The devices, a chip in the device was actually reused. The device was brought back, a chip was taken out of it, and that way you can reuse that device and link it back up to the vendor dashboard. So even though this was relatively brief, it was successful enough that we understood its functionality. And at Summa Health, this program is now going to be reactivated. But instead of COVID-19, it's going to be used to address diagnoses of asthma and COPD. So asthma and COPD patients entering the emergency room who might otherwise be admitted to the hospital, and there's a concern about their oxygenation and vital signs, they're going to be, if they fit appropriate criteria, discharged with this solution. And obviously the benefit here is to improve capacity. And so to make this work, there has to be a close collaboration amongst everyone who's involved in this project. A second form of remote patient monitoring functions somewhat differently. This is a provider-driven order for remote patient monitoring, which can occur in different settings. And we're interested in setting up a pilot, not yet, but we're on our way to doing this, in which our use case is going to be monitoring blood pressure. Now, in contrast to the prior device, which uses continuous monitoring, this one uses intermittent monitoring. So it's intermittent monitoring of a chronic disease, in this case, blood pressure. But this lends itself well to monitoring other issues such as weight and glucose. So the strategy for how this works is shown in the schematic below. This can be set up or started in either the inpatient location or the outpatient location. A provider is needed in your electronic health record to start the order. That triggers the appearance of a flow sheet in which the provider sets what are normal and abnormal values. That gives them triggers. Simultaneously, this electronic health record order goes to the vendor, and the vendor configures a device with a built-in cellular communicator, which is then mailed to the patient. On arrival, the patient can take out that device, set it up. That can be done at home, that can be done in the clinic. And as long as it's working appropriately, once it's been verified to be working appropriately, it can begin recording daily values. Those values are then electronically sent to the electronic health record flow sheet. Once there, values that are outside of the normal range of the normal settings that was input for that individual patient in their flow sheet, those abnormal values are messaged to a pool of clinical staff, which might be a nurse or nurse practitioner. They would follow a management algorithm, and then they would escalate that to a provider if needed for medication adjustments and so forth. To make this work in terms of reimbursement, you need to collect a month of readings, at least 16, to qualify for CMS reimbursement. You need to have a summary report, and a provider needs to attest to those results once a month. So in one of the last slides, I wanted to compare those two strategies. So comparing attributes of these two types of monitors, and then say a few words about billing. So for the continuous oxygenation monitor, as I said earlier, this is a strategy in which the patient brings their own device. You need a Bluetooth connection for that device to work. Whereas our intermittent blood pressure monitor solution, the cellular communicator is actually built in. Now, this is relevant because for patients who are not technology savvy, do not have devices, for one reason or the other, you can extend the number of patients that you reach if you have a device with a built-in cellular communicator. Another feature that should be considered if someone is thinking about remote patient monitoring is whether the vendor provides support. So for the solutions that we were looking at, that I was discussing here with continuous O2 monitor and intermittent blood pressure monitoring, none of those are driven by the vendor direct clinical support. But there are a lot of standalone turnkey solutions that healthcare providers, healthcare organizations can set up where the vendor sends out the remote patient monitoring device, and their nursing staff then addresses all the questions. And you, the provider or the healthcare system, might simply get a notification periodically about the status of that patient. Next, with respect to alert values, as I said, for the continuous oxygen monitor, the alert values were all the same. It was not able to be customized. For the intermittent blood pressure monitor solution that we're interested in setting up, that is set up on a flow sheet in which there's a lot of flexibility, and that can be very helpful particularly with respect to blood pressure. Next, are these solutions integrated into the electronic health record? So for the continuous O2 monitor, the answer is no. It requires a separate dashboard for monitoring and alerts. Now, on the one hand, that's actually beneficial because we're able to stand up that solution fairly quickly. It's self-contained with respect to the device and the vendor dashboard. We don't have to spend time to figure out a number of security issues or how to integrate that into the electronic health record. So that is a quick solution. Whereas for the intermittent blood pressure monitor solution, it is integrated into the electronic health record. A dashboard is also available, but the benefit of having the data in your electronic health record is that anyone can look that up. If there's any concern, whether it's a specialist who's normally seeing the patient or not, they don't need access to the dashboard. The information is right in front of them. And that is not true in a situation where the data is only available on a dashboard, in which clearance to use the dashboard is going to be typically limited to a small number of people. What about the kinds of measurements? Well, by definition, the continuous O2 monitor is continuous, and that requires a call team, whereas the intermittent blood pressure monitor is not continuous, it's intermittent. Those values actually don't need to be looked at on the weekends or during the nighttime. Those values are really only followed up during business hours. And so that really leads to the next question with respect to what kind of clinical support do you have to set up to be able to support this? Well, for a continuous oxygen monitor, you need a call team. So at Summa, we have nurses in a clinical call center that monitors the dashboard 24/7. In addition, as I described earlier, there's a patient engagement component to this, in which patients answer questions, and there has to be replies, and there has to be an ability to respond to those patient issues. So the monitoring is actually fairly substantial. I think it's possible to do this for a small number of patients, but it can become harder to scale something like this. Whereas for intermittent monitoring of a vital sign, that is actually more easily scalable. The RN or nurse practitioner can receive a message from the electronic health record about an abnormal value. And these values are typically addressed during business hours. And so the monitoring is less intensive, and it can be longer. It's not just a month. It can be 3 months. It can be 6 months. And then, of course, there's issues with contracts. Is what kind of contract do you have? And for anything that's built into, that you're going to need to build into your electronic health record, well, you need to build an interface, and there's going to be significant cost associated with that. So that's comparison of two different monitoring solutions, one of which we've already employed at Summa Health, and the second which is in process. So with respect to billing, briefly, CMS has updated their guidelines in 2020. There are one-time charges that you can submit for device setup and patient education, as well as reimbursement for supplying the device. For patients in whom you're going to be using the device for an extended period of time, for a few months, you can use this code. And this code you can bill monthly. It requires 20 minutes of interactive communication, plus whatever non-face-to-face contact that you use to support and evaluate those patients' vital signs. You need a minimum of 16 readings, 16 days of readings in that month to qualify, and then to summarize that visit. So that's for the first 20 minutes. If you do an additional 20 minutes of care in a month, so a total of 40 minutes, you can bill an additional code. So that there is certainly benefit here. There are benefits to this, the continuous CO2 monitor, in which you might improve your capacity management, but you may or may not recover this in terms of billing, whereas you might be able to recover some of your upfront costs with an intermittent monitoring solution, whether it be blood pressure, glucose, or so forth. So in conclusion, using telehealth and remote patient monitoring for capacity management. There are many locations along the care continuum that telehealth and remote patient monitoring can be used to address. It's reasonable to take a collaborative approach between IT and clinical sponsors to try to identify particularly new or unusual tools in which the clinical benefit is not clear, to pull your clinicians into that evaluation and discussion. The benefit is not just limited to a clinical benefit. It might include an improvement in quality of life for the patient. It might include a decrease in bed needs, and improving your capacity management are some of the other considerations here. There's a wide variety of strategies available, as I alluded to, for remote patient monitoring, and understanding your needs, then fitting a solution is most appropriate, rather than vice versa, finding a solution and then trying to fit your needs to it. So remote patient monitoring tools and services are rapidly expanding. We're seeing this even from in the last year, and they are themselves on a continuum of intensity, with the pinnacle of monitoring being hospital at home, which I'm sure we're going to hear more about, and most of us have an interest in. So thank you very much for your attention. I will take questions in the chat or otherwise when appropriate. Thank you very much.
Thank you, Dr. Klauty. You've given us a lot to think about, and I'm sure that a lot of people will be getting back to you in the chat with questions. I don't see any right now, but they tend to come through a little bit later. Our next two speakers are from the Metro Health System. They're going to talk about artificial intelligence redefining the revenue cycle. And these presenters, Jennifer Nikki Davis, who is the Director of Patient Financial Services at Metro Health, and Marianne Olschlager, the Director of Revenue Cycle Operations at Metro Health. So as soon as we get them live, we will bring them up for you. Well, it appears that our presenters are not yet in the backstage. So I think what we'll do until then, we'll take our 15-minute exhibition break. And as soon as you come back, we'll go into their presentation. And from there, we will go into our panel discussion. So let's everyone take a 15-minute break until 1:20. I have 1:05 on my clock right now. Thank you.